Good afternoon, everyone. Live from Houston Methodist DeBakey Heart and Vascular Center weekly multi-modality imaging series. So today we will be talking a little bit more about in detail about the past, present, and how coronary artery calcium testing may be shaping the future of cardiovascular risk assessment. As we deep dive into our discussion, just wanted to start, when I entered medical school or even in the early phase of my career, I got a sense that there was a deep-rooted pride and sense of pride to be more certain, know your diagnosis, know your conditions, options. And in the early stage of my career, introduced to my mentors, and especially someone like Harlan Kromholz, who gave me a peek into this mostly hidden, I would say the biggest secret that's hidden, that in medicine, evidence is often inconclusive. And as someone also getting more versed into the health economics, population health, and coming from a country where we didn't have infinite resources, the trade-offs was not an issue, however, definitely challenging in the US environment. But if we have to figure it out how we're going to spend our resources more effective, it's going to be a more complex, and the priorities can definitely vary in which lens you're going to look from. So the journey of the calcium testing, coronary artery calcium testing, very much you will see will be balanced by the uncertainty and the trade-offs. So to start with, I'll take you back to November 2018 at the American Heart Association annual conference in Chicago. Many of you who might have been there live or have seen the headlines, definitely a big news was the revised lipid guidelines not only boosted, made room, but also claimed a larger role for coronary artery calcium testing as far as decision makings around statins and risk were concerned. And I definitely got a sense speaking with many of us around that, hey, what's the big deal? This is inevitable. But as a keen follower of medical history and fortunate to be part of some of this journey over the last 15 years, I can tell you that the road wasn't as clear. And, the journey of calcium testing really started way back in almost 20 some years before the guidelines in 1990, when my dear friend, mentor, colleague, Arthur Eggleston and his group for the first time showed us that, using a rapid CT scan of the heart without IV contrast, of course, in that era, mostly focused on the remarkable EBCT, but only I would say dedicated for heart scans, but now anything about a 4-slice CT, which is widely accessible, about take 3 to 5 minutes and low radiation dose, you can peek into, non-invasively peek into the coronary arteries to have an understanding or at least some idea about the foundational disease of cardiology, atherosclerosis. And I cannot even imagine the level of excitement it must be in the 1990s when we had this tool giving us a Polaroid camera to look into your arteries. I'm sure that NIH, AHA, ACC, and many of these foundational cardiovascular organizations would have laid out the red carpet. In all honesty, that didn't happen. Actually, a year before, when Dr. Eggleston and their group submitted their abstract to American Heart Association, and many of us, and you might be doing it for the coming session, they were surprised to receive a rejection letter, literally a year before the paper got published. So clearly, the path wasn't that clear. And although right now, hindsight to 2020, you can clearly see the challenges that were out there. Of course, the first 10 years really got them to understand what is coronary artery calcium testing, a very specific marker for atherosclerosis, tracks with disease burden associated with risk factors, and maybe also able to rule out the disease. But it was efforts across the Atlantic Ocean, multi-ethnic study of atherosclerosis in US in 6 sites, and Heinz-Nixdorf recall study in Germany that jump-started in 2000, and finally by 2008 and 9, we had the evidence that everyone was looking for before even considering coronary artery calcium testing, that higher the amount of atherosclerosis, it's about 9 to 16-fold higher risk for having a cardiovascular event. Mind you, in the early 2000s, diabetes was CAD equivalent, which is almost 2-fold higher risk, just to put things into perspective. Among the first markers that can improve your measure of discrimination, but more importantly, meaningfully reclassifying nearly 1/2 of the individuals in the intermediate risk group where decisions about management could be improvised. And as a result, in 2010, really more, I would say, encouraged by the guidelines that started moving into this direction of screening, and suggested that almost 50% of the adult population that is in that intermediate risk group, where you're unsure of their disease, you can screen for people who are not candidates for statins to identify those who may be benefiting more and getting a 2A level A recommendation, which is the highest you can get in an absence of a clinical trial. Many among us were truly encouraged with this trajectory and hoping that the next set of the guidelines would further strengthen this paradigm shift of see disease, treat disease versus the common scenario of focusing on the risk factors. However, in 2013, there was definitely a blind spot from many of us because few things were ignored that were happening parallelly. For example, by that time, we had significant trial evidence of the benefit with statins, even in lower risk groups. By that time, statins were widely available, cheap and safe. Even if from a societal perspective, studies demonstrated that you treat a lot of low risk, it would still be cost effective. And of course, the major challenge till 2013 about missing individuals who should get statins or more aggressive preventive therapy that were missed by the prior risk scores, this would capture majority of those individuals. And as a result, the guidelines downgraded the utilization of coronary artery calcium testing for the purposes of risk assessment that would guide subsequent management decisions. And in this uncertainty, things become a little more muddy when ACC comes out and also suggesting that coronary artery calcium score or no more. And learning from Phil Greenland, one of our recent grand round speakers, and I couldn't agree more, we were all facing this challenge, not only about calcium testing, but almost any risk factors in an environment when, let's say, you're using a certain cutoff where majority of the individuals would be candidate for the cheap, widely available and effective therapy. Why do we need any additional risk markers? And definitely some thought to ponder, but at that time, being an avid supporter of calcium testing screening, I also started questioning my own conviction around that and taking some time to think about what could be the next phase of cardiovascular risk prediction and primary prevention, and looking through the lens of the history and ahead where the puck is going to be. I thought definitely is a difficult journey, but worth the destination. And maybe we have to change our thinking around this. And why did I say that? And, while the biggest factor or the biggest question that we continue to ask in our clinical practice, what is your risk? And we are always looking to upregulate risk to guide management. I questioned that, would that be an important, especially in the situation in 2013, 14, and 15, when possibly we are encouraging a lot of individuals to get into the statin club by a risk prediction model, which overestimate. I felt that the need to identify additional individuals for preventive therapy were less compelling. And looking at upside down, maybe in 2015, our stakeholders were likely going to place a higher value, including our patients, the health systems, and even as physician, in how we can de-risk these individuals and populations, where we can focus more on lifestyle rather than more aggressive pharmacotherapy. And the rationale was that almost 6 years back, coming up with this whole idea, while everyone is interested in what happens when you have a higher burden of disease, we were truly intrigued by this concept of what happens if you don't have any atherosclerosis. And after multiple revisions and getting rejections by almost all the major journals, finally we found home in JACC imaging, thanks to Dr. Fuster and Jagat Narula, where for the first time we suggested that among a significant proportion of individuals, irrespective of your risk, a finding of a calcium score of 0, of course, it doesn't mean 0 risk, and many skeptics would suggest that way, that as a group, you're at such a low risk that you may not need any downstream imaging, and more importantly, you can avoid pharmacotherapy and focus on lifestyles. Of course, there are going to be cases that your colleagues and my colleagues would continue once in a blue moon share on WhatsApp about somebody with the calcium score of 0 having an event, or how they may have an abnormal stress test or some CTA. But again, that just highlights that pretty much uncommon. But in 2009, this concept didn't get as much traction because we were still focused on trying to find individuals who are at risk. The guidelines were much narrow. However, when we broadened the scope of statin candidates, definitely this idea became a little more interesting. And subsequently, from 2009 and all the way to 2016 and 17, clearly we learned very slowly that our assumptions and understanding the uncertainties and also understanding the trade-offs that many among us who walk, who would have significant amount of inflammation or multiple risk factors or significant dyslipidemia, which still remains the foundational risk factor for us in deciding risk and management. Or you can be a candidate for polypill, have family history, aging, and it doesn't matter how you cut, slice, or dice the pie. There is a huge variation. A significant proportion of individuals that we will consider to be high risk and pursue commitment to lifelong therapies like statin or aspirin have a much lower risk than anticipated. And finally, in 2015, working with colleagues all across the country and thinking about not trying to come up with more data showing that the calcium testing is more prognostic, but more looking at it from the lens from the health system and healthcare delivery, where would it impact decisions? And what our finding clearly shows that majority of the adults who are not already on statin would be candidates for them if we pursue the traditional pooled cohort equation. However, if you look deeply, 1 in 2, not a small number, would have no atherosclerosis, but more importantly, if you follow them for 10 years or more, almost exclusively their average risk would be well below the threshold that was instituted by the guidelines for even consideration, not recommendation, even consideration. As a result, almost 7 years back, making an 180-degree shift as far as statins are concerned, we raised this idea for the first time that maybe calcium testing is not about screening. It's more of a decision aid for shared decision making and kind of understanding risk and management decisions, and only for those who are desiring flexible treatment goals. And of course, we had never done any testing in trying to identify those used for shared decision making and especially de-risking, and many other questions came out about what about other tests? What about the cost effectiveness of introducing $100 to $150 test upfront? And what about if I treat a lot of individuals with statins, even if they had a calcium score of 0? The next 3 years were pretty pivotal in the sense that in 2016, we finally learned, working with my dear colleague and friends, Michael Blaha and Miguel Canzos, that even if you take into account a lot of traditional and negative risk marker, including IMT endothelial function, low inflammation, even a healthy lifestyle, family history, across the entire spectrum of risk. It's only an absence of atherosclerosis that truly adds the value to de-risk and pursuing more flexible choices. Furthermore, in 2017, we showed that rather than having a treat-all approach, even if you introduce calcium testing upfront, it will be cost-effective from a societal perspective as long as there is disutility from patients where majority of them may not want to commit to a lifelong therapy if not at risk. And the testing cost is around 150 or low, which is the national average. And finally, my dear friend Todd Villanis clearly in 2018 shattered the myth that even if you treat a lot of individuals with a calcium score of 0 with an average risk up to a 12-year follow-up, you may not see any benefit. Of course, not a clinical trial, more of an observational study. But clearly, the benefit of statin was there for individuals where the disease was present. And if you focused on those with a calcium greater than 100, then all you need to do is treat 11 individuals to prevent one event. Now, with this accumulation, the snowball effect of evidence coming very clearly to a point where we had a tool for de-risking, showed all across the spectrum of the disease that pretty safe, and all of this new information, when the new guidelines finally arrived in 2018, it wasn't a surprise that they acknowledged that substantial advancements happened over that 5-year period. But the key point and the key acknowledgement was, for the first time, accepting this new concept that wasn't out there. Of course, most of us in the peripheries were practicing it and knew it, that this phenomenon, the calcium score of 0, power of 0, indicates such a low risk that you can safely consider downgrading the risk and management. And as a result, in the 2018-19 guidelines, the new role of the calcium testing was identified as a decision aid, not screening. It was upgraded back to a level 2A. And as you can see, the difference between the 2013, where it was more for screening, the guidelines author found it more appropriately for those who are already candidates for statin, and in those who are uncertain, something, the concept that we promoted in 2015, it felt like almost that concept was taken. But for the first time saying, even if you're a candidate for therapy based on our own developed pooled cohort equation, if you have a calcium score of 0, you can avoid therapy and postponing drug therapy. Now, of course, the guidelines took 3 steps forward and took 2 steps back. We're saying, well, if you have some uncertainty and you have some risk enhancing factors, a basket of all the risk factors, which I'll talk about, or you're diabetic or family history or your LDL's more than 190, maybe it's not as useful. But honestly, if we can take the broader look and come back and review this in the next 5 to 10 years, I think so this was a watershed moment where the big ship of cardiology slowly started moving away from this I would say emphasis on risk factors to this whole thing about seeing disease and treating disease. And I'm sure this will continue to propagate even further. Definitely the power of 0 received warm reception from thought leaders like Roger Blumenthal, suggesting that this is the best tiebreaker. My dear friend Ron Blankstein suggested that with calcium testing, you can avoid statins. Harlan was more blunt, saying that this test might tell you if you don't need a statin. And Dr. Grundy, Scott Grundy from UT Southwestern, suggested you should be talking to your physician before getting a calcium testing. Otherwise, too many folks would be on there. And truly the best message coming, a more blunt message coming from Val Fuster, and suggesting that if your calcium score is 0 in this 5 to 20% risk range, forget about the statins. Now, the question really is, it's all about shared decision making, and at conferences, and many of my colleagues continue to ask us, what do you even mean by shared decision making? And I suggest there is no head of the household. So after a lot of back and forth, of course, kudos to Miguel Canzos, who worked with me on this review, where we says, how do we do practice shared decision making? For example, somebody with a 10-year risk of 10 to 20%, And we explain them about statin efficacy, side effects, and cost. But at the same time, if you do not tell these patients that they may have a probability of 1 in 2 that they have a calcium score of 0, it's just going to be hamper their shared decision-making role. And if someone is still willing to commit to a therapy, even with that such a lower risk, then you pursue them on the statin therapy based on their original risk. But majority of the patient like us who decide to spend that $100 to $150 out of pocket to get an understanding where they are on this risk spectrum. And if they have a calcium score of 0, based on that, have more flexible therapy that can go from anywhere from no medication to low dose. And people with high calcium burden will be treated based on how much plaque they have. And I'll explain what our strategy is. But a calcium score of 0 doesn't mean it's once in a lifetime test. And many of the skeptics would suggest that somebody getting a calcium score of 0 will certainly be on the street with a hamburger, a cigarette in the other hand, and gulping down a liter of Coke. That doesn't truly happen. These are the folks who value the absence of the disease and understand on how to continue to keep it and continue follow-ups. So in 2021, as the year ends, calcium testing is now truly established as a shared decision-making tool. But of course, the question is, what's the next 5 years and 10 years? And what I would like to discuss a little bit more where the future is, because I feel that's where you and I will be spending most of our time, and how we can all come together to take the next steps to and try to understand those uncertainties. So where were the gaps? The first gap in the guidelines were uncertainty in risk to guide management, where the guidelines suggested we should be using a range of risk enhancing factors such as family history, CKD, metabolic syndrome, menopause, triglyceride, inflammation, the new kid on the block, lipoprotein A, ApoB, and ankle brachial index. And the question was, among those intermediate individuals where you may choose to use risk enhancing factors, how many of them would have a calcium score of 0? On average, about 40%. And in that, the risk is still around that 5 or low level where you can avoid statins. For example, a 55-year-old with a 10-year risk of 10% who has 3 risk enhancing factors, about 40% will have a calcium score of 0, and their risk is much below the threshold of even consideration of a statin. And it doesn't matter if you have 0 risk enhancing factor. If you have the disease, your 10-year risk is much higher than anticipated. So the question really from us was, and at least from my standpoint and many of others who share the same sentiment, why even bother? I think so that in the future, we should be starting with the calcium test first. The second thing was about diabetes, considered risk equivalent, and say their risk is high enough, so we do not recommend getting calcium testing because it may not de-risk. However, subsequent studies coming from Matt Budoff and Shaista Malik clearly showed not all diabetic are the same. A significant proportion in type 1 have a calcium score of 0, as well as in type 2. And an absence of a calcium score in follow-ups extending 10 to 12 years really represents the power of 0. Again, the warranty period of the calcium testing holds in this group. Someone with the diabetic with the calcium score of 0 is much lower risk than a non-diabetic who has a calcium greater than 100. And potentially, you can use that to have more flexible goals. So the question really is, can we start now moving away from this concept of diabetes CAD equivalent to actually high calcium scores as a CVD equivalent? And I tried to summarize a little bit of this in this New England Journal group of topic update. And this is what broadly our practices are in those 10-year risk of 5 to 20%. If you have a calcium score of 0, the focus is truly more flexible goals. Repeat calcium testing in 3 to 5 years, depending upon what your baseline risk is. And Michael Blaha's group has shown clearly on which are the groups that you may think about bringing back in 3 versus 5 years. If you have atherosclerosis, the guidelines in the prior guidelines suggested that, you should have a more of a shared decision-making. I think so. This is a clear indication of initiation of a statin. Of course, you don't need aspirin. Whereas if you move to this whole calcium greater than 100, you should be considered CVD equivalent with a high intensity statin getting your LDL below 70. Aspirin, a lot of data has come from Miguel Canzos and Amit Khera's group, clearly shown the benefit of aspirin versus the bleeding risk is significantly higher if we model that based on the outcomes and trying to get their systolic blood pressure less than 130. We have now multiple, a couple of papers coming from our group suggesting that icosapient ethyl would be a great consideration, as well as the SGLT2 and GLP-1. So this is in a nutshell of what we think that our consideration of CVD equivalent should move from higher estimated risk to actual disease burden. Now, a clear challenge in 2018 guidelines is, as preventive cardiologists, as primary care, and I'm sure many of us continue to see these individuals with severe hyperlipidemia defined with LDL more than 190. And the question is, are all these patients the same? Do they need the same aggressive therapies? And definitely the whole uncertainties and the trade-offs. And many individuals in the general public continue to see these patients with the calcium score of 0. And clearly, as Michelle pointed out, this is a guideline-free zone, but no longer. In 2020, this fantastic paper from Johns Hopkins and Mesa showed that 35% of individuals with LDL greater than 190, if you follow them for 10 years or more, their event rate is much below the 5% threshold. And an amazing editorial by Moaz and Marcio highlighted the point that the power of 0 has passed another test. So clearly, they may still be candidate for statin, but at least in the spirit of transparency, disclosing that they may not be as high risk as anticipated. Another space that, which moving on to the next phase, is what about actually those who are genetically confirmed familial hypercholesterolemia? In general, considered, I would say, the human model for atherosclerosis. And after doing a due diligence of the published literature, we found that almost 45% in that middle-age group of familial hypercholesterolemia, even with exposures of LDL for 35, 40, 50 years, have no underlying coronary calcium score. But does it really matter? And it does. Raul Santos and the group showed that among the 40+% with calcium score of 0, actually they're up to 10 years and the median follow-up 5 years, the event rate is 0. It really the presence of atherosclerosis that predicts. And putting all of this thing together in the peace of our mind, considering that they may all be candidate for the PCSK9, which is expensive, and more advanced therapies. And do we even need that? We may potentially be able to avoid that. And one common, I would say, message that goes out, that maybe we are suggesting that in a calcium score of 0 with familial hypercholesterolemia, you don't need statin, but that's not the case. Maintain lipid-lowering treatment, continue to monitor the CVD risk. PCSK9 only if your calcium score is more than 0. The third future, I think so, is going to be piece in how calcium testing can help design the future primary prevention clinical trials. I think so. This is a fantastic and a very exciting space, especially with the growing number of therapies that we have, PCSK9 monoclonal antibodies, RNAi, eventually gene editing, icosapient ethyl, the whole cardiometabolic. And how do we bring them from the secondary prevention to the primary? And we believe that the risk is going to be more heterogeneous. If you based it on the risk factors, you'll need a much larger population, much higher cost. And we can learn lessons from our oncology colleagues of this whole double enrichment, where you include individuals with a certain level of perceived risk and just focus on those with the higher burden, but definitely excluding those with the calcium score of 0. Now, how would that pan out? And in this paper by Miguel, clearly looking at almost all the options in a slightly higher risk group for 10-year of 15% or higher, or maybe even diabetics, clearly those with the calcium greater than 100 and especially greater than 400 pushes you to that level where your risk is above and beyond, or even close to a secondary prevention. And likely you'll need the smallest sample size for the clinical trial and the lowest cost. We are pretty excited. Many of these discussions are ongoing. Even some of the PCSK9 studies have a small group of the calcium testing, but I'm very confident that majority of the clinical trials in the future, especially in the primary prevention setting, will have one or another element of the calcium testing out there. The other options is, what about testing among the youngs? The guidelines suggested, rightly so, that for shared decision making, it's the age 40 to 75. That's where the data was. But from 3 further downstream studies after the guidelines, an approach was shown that targeted identification, those with at least 3 or more risk factors, especially if you have a premature cardiovascular disease or metabolic syndrome, we can identify literally 1 in 3 or 1 in 4 individuals aged less than 40 who may have the earliest plaque. And the concept would be very aggressive treatment to shift the trajectory. So I believe that age is just a number, and we are primed for lowering the bar for the coronary artery calcium testing. Now, parallelly, over the last 20 years, we also have significant advancements in the multi-detector CT technology that now, with just a scan in one heartbeat and with significant low radiation and with contrast, we can not only understand the plaque, but a lot of the hidden plaque burden that's not captured by the calcium testing and the features such as non-calcified, mixed, high-risk plaque features, and the whole distribution. This is definitely, I would say, the foundational issue that has not well been studied. And definitely there are huge gaps as far as the primary prevention population is concerned, that we have no idea what is the coronary atherosclerotic disease burden and prevalence. What about the so-called non-calcified plaques and high-risk plaque features, and how does it interplay with the calcium testing? More importantly, I think so the environment is right for us to truly push the agenda on trying to understand the biological, social, environmental determinants of early atherosclerosis, and does it add above and beyond in the outcomes? Now, if you look at the NHLBI studies or where the evidence will come out, the cupboard is truly empty. And however, taking things in our own hand way back in 2015, and kudos to this initiative supported by a large health system, Baptist Health South Florida, we launched the Miami Heart Study, where recruiting 2,500 individuals for the first population-based cohort in the country that has not only the imaging, but also the biobank, apart from an extensive amount of the data that's out there. And we are so proud that just this week, we published the first finding of coronary atherosclerosis using CTA in an asymptomatic population-based cohort of about 2,500 individuals with a mean age of 50% women, significantly Hispanic predominant. And you could see that huge distribution of calcium versus more plaque found, especially the non-calcified plaque. Almost about 6% have stenotic disease, almost 7% with high-risk plaque features, and even some plaque found in about 16% individuals with a calcium score of 0. But any significant disease such as maximal stenosis is less than 1%, and high-risk features about 2%. Now, I think so this is such a fantastic asset that will continue to have a snowball effect and give us insights on the secrets of CAD, but more importantly, what does an exclusively non-calcified plaque means when these individuals are followed for the 5 to 10 years. Of course, the answers would not come in soon, but I'm very hopeful that at least in a couple of years, we'll have the first 5-year follow-up to give you more updates. So now this is the world that we live in, mostly in the preventive cardiology as far as asymptomatic is concerned. And, I still believe, and over the last 10 years, when the concept of power of zero came, it was originally promoted really for the symptomatic individuals. And I know that over the last 10 years, there's have been a lot of back and forth, and this is a line that many of us do not want to cross. But I'm saying, can we dare to be a little brave and try to keep the sentimentality out, and let's look at the data. Finally, I think so even ACC and AHA is tiptoeing into this space, because if you look at the newest guideline update, clearly they have suggested that calcium testing can be used as a first line to exclude calcified plaque in the low risk. So I think so they've started to get some courage in trying to accept the power of zero. But my question is this enough? And we'll continue to push the agenda and the envelope. And the rationale why is that clearly in our clinical practice, and even from contemporary cohorts, almost about 90% of individuals who appropriately are getting either a functional testing or even anatomical testing as a CTA. By the way, CTA is such an amazing test in ruling out disease for symptomatic. But can we do better? Can we have less advanced imaging to be not abnormal? Can we consider staged testing? Can we dare to be brave? Can power of zero be the solution? And of course, there has been tremendous amount of data, and this could be a whole discussion for an hour, but I'll summarize some of the key things. And we don't have to look beyond PROMISE, where Matt Budoff clearly suggested that an absence of calcium testing or a calcium score can rule out a significant stenosis, and more importantly, a meaningless stenosis with almost precision of 99.5%. Now, depending upon which side of the bed you woke up, either the glass is 99 to 100% full or 1 to 0% empty. But the key thing for me from this study was not only in the context of calcium testing to rule out disease, but more importantly, how does that compare to the most commonly used testing, functional testing in the country? And if you look at that, where normal function testing has almost in the follow-up 2 to 3 years had an all-cause that MI, unstable angina of 2.1% to CV death and MI 1.3%. If we are reassured with that, I think so we should be even more reassured with an absence of a calcium score of 0, 1.4%, and 0.6. And every time I bring this up, one of my colleagues and friends do send me that one case that they have seen where somebody has a calcium score of 0, but this is the data, and they would be much easily reassured with the normal function testing, but have doubts with the implicit bias with a calcium score of 0. But this is not the data that's alone. And I couldn't agree more with Matt Budoff that eventually the direction we have started to move in, this should become the standard of care, where most of the low risk, at least, and low to intermediate risk calcium testing should be used as the initial test. And the data is supported by PROMISE and also in Crescent, which, by the way, was a clinical trial in which they demonstrated that by doing calcium testing, you can avoid almost 40+ CTAs. And of course, the same thing can apply for a stress testing. And in 2 years of individuals where no further testing was done, they had no events. Clearly, the calcium of 0 in symptomatic low to intermediate risk individuals have an excellent negative predictive value. I think, and I agree with Kuhn, that its incorporation is justified in the CTA algorithm. And you can avoid contrast medium in 39% of the patients, are maybe much more applicable right now, where we are running short on the contrast and people would suggest doing stress test or more nuclear. I would say, why not just go with the calcium testing? And there is no indication that the implementation of the calcium scan in patients with a low intermediate probability is unsafe. This is coming from our current SCCT president. But it's not only about the short intermediate term follow-up, even in follow-up extending up to 13 years, where we know that the power of zero excludes stenosis by 99.5%, but it holds even a greater power in ruling out events where 0% individuals died of a coronary event up to a 13-year follow-up. And who could disagree with Tarun and Adam that they rightly so question the utilization for further testing in your symptomatic patients if the calcium score is 0. Well, many would argue that, and we still see about few percent of individuals where who have a calcium score of 0 and may have an abnormal perfusion study. But if you look at data from Engbers, and this data, I'm just giving you a summary, has been well validated by Dan Berman and Alan Rosansky multiple times, about 5,000 individuals. All of them are intermediate risk, and a nearly 4.5-year follow-up, about 1.2% annual MACE events. Ischemia, if any, with the calcium score of 0 is exclusively mild. But when you look at the risk here, it's almost as good as having no ischemia. So in essence, if you think about what Engbers think is that the addition of SPECT myocardial perfusion imaging, and I would argue even a PET or any other testing with a calcium score of 0 could lead to unjust invasive imaging with additional cost, risk of complications. Therefore, SPECT MPI or advanced testing may not be useful in a calcium score of 0. And of course, these are good arguments and laying the ground for hopefully where all of us can come together to test this hypothesis in more of a clinical trial settings. But what about the chest pain patients? Acute chest pain, folks who walk into the ED now from Brian Ghoshajra and their group in MGH, who has done a lot of, I would say, given us the insights on the acute chest pain. They have also shown that among patients, if they have a TIMI 0 and a calcium score of 0, you can rule out ACS with 100%. And I couldn't agree more. Identification of the calcium testing in the real world clinical situations provide an excellent negative predictive value to identify those at low risk for not only obstructive, but ACS. And it can help improve patient management in setting where advanced imaging is not available. And I would add, even if they're available for appropriate utilization, just because we have them available doesn't mean we have to bring out the big guns all the time. And, this is a classic paper that I always look back, and I can tell you that have inspired me the most, the 2010 paper by Faisal and John that did an amazing study taking 1,000 patients who come to the ED with negative troponins and EKG. And as a fellow at that time, where usually we go out and stress them, and if it's normal, send them back, they added the calcium testing and found less than 1% of individuals who have minimal amount of ischemia if they have a calcium score of 0. By the way, more than half of them had. But when they followed them up for 7 months for MACE events, while the SPECT is pretty favorably prognostic, only 1.2%, which is the threshold that we use in the ED, around that 1%. But if you would have made those decisions with a calcium score of 0, the event rate was 0.3% as compared to 1.2. And, Faisal and John, thank you for giving me this data, because I clearly remember many years back when in a debate when somebody asked me that, how would you sleep sending somebody with an acute chest pain back home? And I said 4 times better. And definitely this was kudos to all your data. So thank you so much for giving me that opportunity to respond back. But not only responding back, we took things into our own hand at Baptist Health South Florida, where a robust program of CT angiograms was established by Jack Ziffer and Ricardo Curry. And looking into the data, what we found, again, very much similar to Faisal and John's data, almost 56% individuals had a calcium score of 0 who underwent CTA for chest pain rule out. And the negative predictive value to rule out obstructive disease was 99.3%, and less than 1 in 200 individuals required revascularization, which one can even doubt whether that was even needed. So again, extending the data all through that, and now doing an even more due diligence all across the studies that have used CT and the calcium testing of more than 90,000 patients, about 80,000 with stable chest pain and about 12,000 with acute chest pain, in a paper that's in press showing clearly a negative predictive value of 97%, even including the ones that might not be the best studies to include, but reducing the bias that you can improve it by 98%. Now think about it. Calcium testing is still a class 2B for the low risk, whereas a lot of the other testing functional testing, be it stress imaging by MRI, SPECT myocardial perfusion image test echo, have a class 1-ish recommendation, and with less diagnostic and prognostic value in the setting of a normal studies. And just to add a little bit of humor out here, that what would other modalities, if they had the same diagnostic and prognostic performance as we have seen with the power of 0, definitely they will be jumping up and down with joy, and you would be seeing trending on Twitter just as for CMR, nuclear all clear, stress echo every day. But this is just some humor in trying to put things into perspective, that despite all of this significant prognostic data on the absence, we are still avoiding that. I think so the time is right, as the puck is moving into value-based performance, where the sequential testing can be incorporated into our pathways. So to put things into summary, clearly what you can see is that as far as primary prevention is concerned, one size doesn't fit all. The current role of the calcium testing is truly to overcome the fallacies with the risk factors and biomarker approach, where many of these patients would likely to be overestimated and underestimated risk. And clearly, what the calcium testing does, it's a precise decision tool, because it is the disease and it reclassifies irrespective whether you're low, intermediate, or high risk. At the same time, calcium testing is not for everyone. If truly the risk, baseline risk on the aggregated risk profile is higher, maybe you can avoid it. And many of individuals who may not want to be treated or want to be treated irrespective, this is not for them. The power of 0, the main function in 2021 and now 2022 is that it allows flexibility in statin choices. But I think so now, over the last 3 years, we and many others have shown that it can also guide treatment decisions beyond statins for cardiometabolic therapies, advanced therapies, aspirin, blood pressure goals. And clearly the next guidelines would need some more upgrades. So if I had a crystal ball and looking into the future and maybe 5 years at the most, I think so these are my top 5+1 future roles. One is that clearly we'll be starting with the calcium testing first, and the likelihood that the risk enhancing factors will be downgraded, whereas the calcium testing would be upgraded in the face of uncertainty. There will be an acknowledgement that not all high risk are the same, which the current guidelines have, like diabetes, severely elevated LDL, and familial hypercholesterolemia. I believe the calcium testing, and not only believe, we have shown, at least from a risk profile, there is a significant role to guide not only treatment choices, which is beyond statins, but also their intensities. This piece truly excites us that the next clinical trial recruitments for all of these advanced therapies in the primary prevention likely will be using the double enrichment concept with the most value that is going to come from the calcium testing. I believe that age is just a number. We are at the crux of where we can expand testing in a more targeted approach in individuals who are less than 40 with multiple risk factors. And clearly, in the next 5 years, the CTA is going to play a huge role in helping us understand the plaque biology. Anybody who's interested out there, I would welcome any collaboration and any insight in trying to leverage the exciting Miami Heart Study at Baptist Health, South Florida. Also, I think so the final +1 is that I'm happy that the guidelines at least acknowledged. Of course, you can see my message was not accept, but acknowledge. And I think so the guidelines have acknowledged the 221, but we can go beyond, because clearly now we know you can rule out coronary artery disease with the highest negative predictive value. It's an extremely safe, even in the real world and RCT settings, and the prognosis, favorable prognosis, extend up to 13 years and a mean follow of 5 to 10 years. And for ACS, we can rule 99 to 100% negative predictive value with that. So, but I think so we all need to have more imagination, think a little bit, stay away from sentimentality, focus more on data. And if we have the courage, I think so we can accept the power of zero. And not many places are ripe to test these hypotheses and incorporate. So I look forward to more collaboration with my colleagues here and all across the country and globe. So thank you so much. I'm going to stop sharing, and I look forward to your comments and any questions as well as feedback. Right, let's see if I have comments. Faisal, any thoughts?
Khurram, great job. As usual, you've shown us, you know, a real role model in this field and how to, you know, come up with an idea and really carry it through and keep on, you know, finding new opportunities. So I really appreciate that. You know, I think you're absolutely right. We have great opportunities here at Methodist. We've got all the imaging modalities. We've got a big ED population. You know, I think it's high time we test some of these ideas in a prospective fashion and really help you change the guidelines.
So, Nasir, I agree 100% with what Faisal said, but and I've been practicing pretty much what you've been preaching. The only thing is I have been shy of practicing it when the age is under 50. So I'm all gung-ho, 50 and above. If there's zero, I reassure them. If they have a typical chest pain, I don't go to anything fancy. And not uncommonly, I don't use a statin. Now, under 50, I'm still shy. So I would like your comments on that. And then the second thing I like your comment on, which I actually put in as a question. Not uncommonly, we see these 60, 58, 65, 70-year-old women, for some reason, more women. Calcium score is 0. They have some hypercholesterolemia, and they have a few plaques in their carotids. So the question is, do the few plaques in the carotids change our decision making? So those are two questions, and I'd like to have your comments on.
So, you know, wise practice. With the first question, as you see in my editorial, we used almost the same approach, asking, at least because of the uncertainty. It's not because that's true, but because of the uncertainty in the data, that let's keep the calcium score of 0, at least for the symptomatic age more than 50. However, Miguel, as now recent studies, one from this large West Denmark cohort that we participated, they came in and showed clearly that actually, the negative predictive value, that means in an absence of a calcium score of 0 having significant disease, if not better, is similar even among age less than 40 to 55. So this whole concept that we may be missing extensive non-calcified plaque obstruction, it's not true. When we looked into the Baptist Heart cohort of our ER, more than 5,000 CTAs, and I'll share the data, we found the same negative predictive value as far as ruling out the disease and ACS in an acute chest pain phase. So stable patients, we have now the data, and also the acute chest pain. I think so it's a great idea. We may just do a small paper trying to highlight that fact, because many of us, and I was one of them, also had the same doubts. So that's number one. Number two, you pointed out, as you know, just because you have no plaque in the corneas doesn't mean you can't have another vasculature. Most of us, most of the patients will have aortic plaques, right? And lower extremity plaques, but hardly that plaque rupture and stabilization hardly cause an event because of the large sizes, whereas in the corneas, that's always an issue. In MESA, they did find almost 10 to 15% with the calcium score of 0 who have mild carotid plaque, 60 years mean age, mostly women, as you pointed out. And yes, there was a slight increased risk of an event, but still below the 5% threshold. And when they estimated, it came out that you might need to screen or do all carotid screening in more than 1,500 individuals to find one that you may benefit. So yeah, it does benefit. It all depends where, based on the uncertainties and
the question is statin or not statin?
So the questions really, I leave it up to the patients. So my practice is I never prescribe statin. I give the risk, I give them the options, and statin is a great wonder drug. It lowers LDL, lower inflammation. It's much better than a lot of the supplements that we take. So if you think,
what do we know about statins in mild carotid disease? Is there any good trial, anything out there to say you will prevent strokes? Because I'm not concerned with an MI. They have a calcium score of 0. The only reason to give the statin is to prevent a stroke. Do we have the data?
So the data, yes, from the MESA, they looked at ACVD, including strokes. And even including strokes, the risk was not 0, but extremely minimal, where, if you would have seen that risk in the general population, you wouldn't have done that. But, there is uncertainty. And that's what I tell everyone. A lot of what we do, we don't have the data. We just have to put things together, not have a paternalistic view. In a shared decision making, get the patient into the business of shared decision making and let them help decide. So I think it's absolutely fine putting them on statin as long as the patient understand that the benefit, if any, is going to be minimal. Good. Well, if we don't have any questions, thank you so much again joining this afternoon and the opportunity to present. And hopefully this conversation would have stimulated some discussion. I'm hoping that the fellows and the imaging fellows we can all think a little bit more in leveraging our local Houston Methodist, Miami Heart Study, MESA, and many of the other cohorts in trying to continuously answer the questions that come our way, such as what Dr. Quinones has pointed, and how can we change the future? That's the key point. So thank you so much again for this wonderful discussion and the time. Take care. Bye-bye.